Good morning. Why don't we, or good afternoon. Yeah, we had the same problem last time. You don't get good pick up. We want to use this instead. All right, we can just repeat the questions or something. You're gonna have to use this, Bill or Jill.
I'm just gonna say something very quick and then give it back to Chris.
Yep.
Is it on?
Yep.
Yes. Here, but you have to remember, there's people online. We have 59 people online right now. It's much better to be in the room. Okay, we'll go ahead and get started. I want to welcome everyone. I'm Jill Rockbeisel, the chair of the department, and wanted to welcome everyone to Grand Rounds. I'm going to hand over the mic to Dr. Morano for the introduction of our guest speaker, but I wanted to say thank you to everyone that is here in person. I think it's really, as evidenced by difficulty getting us started because everyone was talking so much, it's great to be back in person. I also want to welcome everyone online. We have 61 faculty online participating as well. So again, it's always a challenge to monitor questions. Do we have someone watching the chat? Dave, are you guys going to do that? Great. So we have someone watching the chat for your questions that come in remotely. And then of course, everyone in the room. Probably need to share a microscope. I was just talking to Todd about microscopes. I'm converting a microphone so that when you do ask questions in the room, people online can hear the questions. Oh, we have mics. Okay, so if you're going to ask a question, make sure. So with that, I'm excited for today, and I'll hand it over to Dr. Morano.
Thank you very much, Dr. Rockbeisel. Again, welcome everyone, and thanks everyone for coming. I knew we'd have a good crowd today because we have a very special speaker, and I know a lot of folks are excited to have him back, including me. So today I would like to welcome William Reginold as our speaker. Dr. Reginold, he studied medicine at McGill University in Montreal, hence he is an MD-CM. He later trained in his internship at Johns Hopkins Bayview and completed his psychiatry residency at Johns Hopkins Hospital. And he did old age psychiatry time at the Maudsley Hospital in London. Currently, he is the senior research physician and the medical director of the non-invasive neuromodulation unit in the experimental therapeutics and pathophysiology branch of the NIMH. There he collaborates with a research team investigating electroconvulsive therapy and transcranial magnetic stimulation, predominantly in the treatment of major depression. As most of you are aware, prior to joining the NIMH, Dr. Reginold was here at the University of Maryland in the Department of Psychiatry, where he was the director of the Division of Geriatric Psychiatry, Adult Inpatient Services, and the Electroconvulsive Therapy Service. Dr. Reginold, while his research at the University of Maryland focused on mood disorder pathophysiology and electroconvulsive therapy. And let me just say on a personal note how wonderful it is to have Bill here today. I may have told people this story, so I apologize for repetition. I never thought I would go into psychiatry, ever. And I had my third-year rotation, spring of 1999, on Unit 12 East with Dr. Reginold as attending physician. And his enthusiasm for the care of the patients, his enthusiasm about teaching, his enthusiasm in learning more about our field really was infectious and drew me to the field. And I was actually really impressed then. I said, wow, this is a really normal guy, and he's a psychiatrist. Now, I later learned about the lack of air conditioning and lack of cable TV, but he's still a regular guy. But really, I think Dr. Reginold has been an amazing mentor to me. Once I expressed interest in psychiatry, he mentored me in research, and really, I don't think I'd be where I am today without Bill's guidance. And I know he's done that for a number of folks. And we're just really happy to have him here, and welcome back, Bill.
Thanks, David. All right, great. Thanks, David. Thanks a lot, Chris. I appreciate that introduction, and it means a lot to me that you say that. I'm glad that I was inspiring. That's I think probably the best compliment I can get. And I would love to spend this time catching up with people, but I'm supposed to give a talk, so I will do that. The talk is electroconvulsive therapy: how to make a highly effective treatment more acceptable. I got some disclosures. So our research group is funded through an intramural grant. Number is there. Some other disclosures. I work in the largest hospital in the world devoted solely to clinical research. There it is. It's got 2.5 million square feet. I looked up University of Maryland, very close, 2 million square feet. I had really no idea what square footage it was. But lest you think that we work in lavish comfort here and this is an extravagance that we can ill afford with our taxes, I'm here to reassure you with my last disclosure that it was a big come down from my high ceilinged, large office with the world's best view of the Bromo-Seltzer Tower. But I still am just a few feet off of the inpatient unit here, so that's a good thing probably. Those are the disclosures. Now, the objectives that you can hold me to here, I'm going to talk about the history of ECT and talk also about the therapeutic effects of ECT and some of the data for that, also the effects on memory. And then a little bit about what research we do into the mechanisms of the therapeutic and adverse effects of ECT in the group I'm in. So I'll get started. What is ECT? For those of you who aren't familiar, it's an FDA-approved treatment that involves the serial induction of generalized seizures under brief general anesthesia and neuromuscular blockade or paralysis, which we usually don't use that word with the patients, using alternating current applied through scalp electrodes. It's performed by an ECT credentialed, typically psychiatrist, assisted by an anesthesiologist and nursing staff. It's given as a course of treatment, usually 6 to 12 treatments, and here in the US, thrice weekly, typically. And most common diagnostic indications, usually treatment-resistant major depression, unipolar or bipolar. And other FDA-approved indications are bipolar mania or mixed states, catatonia, treatment-resistant schizophrenia, or schizoaffective disorder. It's relatively safe, and it can be given as an inpatient or outpatient procedure. So how did we get here? Seizures to treat mental illness. Seems kind of crazy, really. Our friends in neurology try to prevent seizures, and here we are inducing them. It goes way back. We're not sure how far back, but we do know that in the 16th century, Paracelsus documented using camphor by mouth to produce convulsions and, in his opinion, cure lunacy. And you can see why he's called Paracelsus. His given name is incredibly long. And camphor, this is what camphor looks like in organic chemistry land. Camphor, interestingly enough, came from the Far East. So really, it was global trade that I guess made convulsive therapy possible initially. So originally, it was injections to induce seizures. So Ladislav von Meduna, Hungarian psychiatrist, injected camphor in oil to induce convulsions in a person with catatonic schizophrenia after first experimenting in guinea pigs. That was 1934. And camphor was eventually replaced by other drugs that had better solubility in water and therefore better, more rapid onset of action, so they could be injected into the bloodstream quickly and work quickly. However, the problem with all these drugs was that you give the injection. I've never witnessed this, but I have witnessed people having auras of dread with seizures. I don't know if others have, but some people, when they have seizures, become horribly frightened beforehand. And apparently this was usually the case when you induce seizures this way. And so because it's a series of treatments, a lot of patients would balk after the first treatment. So many times they wouldn't finish a course and it wouldn't be highly effective. So the thought was, how do we induce these seizures without causing this problem? And that's where electricity came in, and two psychiatrists in Rome. So in 38, Ugo Cerletti and Lucio Bini first electrically induced a seizure in a 39-year-old man who was delusional, hallucinated, and was wandering around the Milan train station. Not quite sure of his diagnosis, could have been mania, could have been schizophrenia, we don't know. And this is now a museum piece. This is their machine. These are the electrodes. This is like, I think, lamb's wool that was soaked in saline and then put on either side of the head, sort of bitemporally. And that man had 11 treatments, and they recorded that he had recovered from that. And then in the US, the first time ECT was used was apparently in 1940, and it was first used at Columbus Hospital in New York City by a couple of Italian-American psychiatrists using a device they got from Rome. So since those early years, ECT has been refined quite a bit. One of the first refinements was in the 1940s, where paralysis was used to prevent the convulsions and possibly broken bones. So when the seizure would be induced with electricity, often people would have very violent convulsions. They'd be held down by orderlies, but sometimes that wasn't sufficient, and people would break bones. And of course, that's a horrible complication. In my research, I realized, I was surprised to find this, but the first large-scale use of curare-derived paralytics in medicine was by a psychiatrist, Dr. Bennett in Nebraska, published it in JAMA in 1940, preventing traumatic complications and convulsion shock therapy by curare. And here we see our Amazonian hunter, who is using curare to paralyze his quarry. Then in the 1950s, succinylcholine came around, and succinylcholine is much easier to use as a paralytic because, as most of you know, it's very short acting. The thing about the curare base is they act longer, and they need a reversal. So more difficult to use. Succinylcholine easier to use. And then actually the barbiturate general anesthesia for ECT came after that. And the reason for that is that being paralyzed, of course, is a frightful experience. And insofar as you're awake and paralyzed, you again say to the doctor, I don't want to have another one of these treatments. And so to make sure that people did not have that experience, they were given barbiturate general anesthesia, initially sodium pentothal, now methotrexate, to prevent that. So those are the major refinements. And then in the 70s and 80s, when it was recognized more and more that there were memory problems with ECT, people started playing around with the stimulus itself. So, so the house current we all have at home is a sine wave, and that it works quite well. But it was found out that if you give sine wave current, you induce a lot more memory problems than if you use this bidirectional brief pulse current. So that was a major change in the 70s and 80s in terms of the devices people used. And the idea there is you can use considerably less energy. It's a more efficient way to induce a seizure. Also, changes in electrode placement came along. So initially, it was the bitemporal placement that you see here, one electrode in each sort of temporal socket, and then came along right unilateral and bifrontal, and both of these typically spare sending current through the left temporal lobe, which in most people is very highly involved in verbal memory. So how common is ECT in the US? Around 100,000 people per year are treated, and that's around 2.4% of all psychiatric admissions. Who's going to respond to ECT? Well, whether you have unipolar or bipolar depression, your chance of response is equal. Your chance of response is really good if you have psychomotor retardation or catatonic symptoms. If you have accompanying personality disorder, this can decrease the chance of full response, because obviously ECT is not going to affect a long-term personality disorder. And insofar as your unhappiness is generated by that, ECT is not going to give you remission. Psychosis is a predictor of good response. Older ages, high suicidal intent, longer duration of episode, however, as in most treatments, is not a good predictor of response. And gender is neutral. So a lot of the features of severe depression, psychomotor retardation, psychosis, suicidal intent, actually are predictors of good response with ECT. Talked about age and ECT. So if you're older, you tend to respond better. If you're older, also you tend to get ECT much more commonly. So these are inpatients with recurrent major depression, and folks who are between age 18 and 24, you can see that below 5% of those folks get ECT. But if you're in this 65 plus group, it's in the range of around 20%. And in that vein, I'll give you a case history of somebody we treated here a while ago at University of Maryland. Kind of a classic case of somebody getting ECT. 75-year-old man who was brought to the ER by his family after a year of severe medication-resistant major depression with psychotic features. He had a 20-pound weight loss, and the depression had developed with a stressor. He moved from Florida back to Maryland to live near his family, and that kind of move can be stressful. It seemed to trigger this. And he was psychotic in the sense that he was tortured by a delusional belief that he'd made a terrible financial decision that ruined his family. His past medical history was notable for a stroke he had 9 years ago with right-sided weakness, which had resolved. Here's his CAT scan, and you can see the encephalomalacia here with his left frontal, and here in the more left parietal region. So he had some significant stroke. He didn't have any prior psychiatric history, however. So in terms of his treatment, he was admitted here to 12 East. He was given intravenous fluids for dehydration. And with his wife's encouragement, a lot of encouragement, he consented to ECT. And his depression and psychosis remitted completely with a 9-treatment course of ECT. He was discharged in antidepressant meds. And over the next 5 years or so, he had another couple courses of ECT for lesser depressive episodes. But overall, he enjoyed the rest of his retirement, particularly his family activities. He eventually did die of other causes. I actually went to his funeral and met a lot of his family and friends, and it was a pretty moving experience to see how active he was in his retirement. So it was very satisfying. So what is it like to get ECT? Well, it usually happens in the post-anesthesia care unit or PACU in a general hospital. And here you see the setup. This is the anesthesia cart. This is the ECT cart. Typically, it's given 3 times weekly, Monday, Wednesday, Friday. And you have to have an IV catheter placed for the anesthetic and the paralytic. Patients won't eat or drink anything after midnight, so their stomach's empty. Takes around only 15 minutes to have the treatment. And the therapeutic benefit and adverse cognitive effects are assessed at least weekly with outcome scales. So what do we use to induce the seizures? Right now, there are a couple of devices on the market. There really are only 2 companies in the US that provide these devices. I won't belabor them, but I will say that the current amplitude, the highest current amplitude that they deliver is 0.9 amperes. And just to put it in perspective, your regular household current is 15 to 20 amperes, so considerably lower. The highest amount of energy that they can deliver in the US is 100 joules, and put that in context, the automatic external defibrillators can deliver 360 joules. So it's considerably less current than you'd get with some other medical devices. I've got a little video here, courtesy of a group in Canada that I found on the internet, and I think it's pretty illustrative of ECT. It's better than my standing up here talking, so I'm going to play that. Hope it works. I like that video. Whoop, wait a minute, hang on. So she, I think, was getting maintenance ECT, and I'll talk about that a little bit later, but she didn't look horribly depressed because I think at this point she's out of her depression and she's getting maintenance treatments to keep her out. Some people require that. So just to kind of go over a few things we saw in the video, usually the patient's wearing a gown, or in her case, as an outpatient, they let her wear street clothes. People get a lot of monitors put on them, electrocardiogram, pulse oximeter. We inflate a blood pressure cuff to keep the paralytic from going into an area, into a limb. You saw her feet move, and that's probably because they had at least one cuff on her foot to keep the succinyl choline from going into the foot to measure the convulsions just in that foot. The rest of her body was pretty much still. When we get an EEG recording, so we can decide if they had a seizure on the basis of that, or by looking at convulsive movements in the foot. And she had, I think, right unilateral ECT. This person has bifrontal electrode placement. So to go over again, for ECT, it's all that we place a bunch of sensors, we place a stimulation electrode, monitor vital signs. Sometimes there's pre-medications. If we know somebody's heart rate and blood pressure is going to get particularly high, we'll pre-medicate them. Blood pressure and heart rate do go up with ECT typically. The anesthetic's injected, the blood pressure cuff's inflated to keep the paralytic out of a limb. Once somebody's unconscious, the paralytic is given. And then they get mask bag ventilation with 100% oxygen by anesthesia, because once they're paralyzed, they can't breathe on their own. And once they're sufficiently paralyzed, they get the stimulus. And the initial stimulus is usually based on age, and then we sort of titrate it to their seizure threshold, trying to give the least amount of energy possible. And we either induce a seizure or we have to re-stimulate. And like I say, we observe for convulsive movements, look at the EEG for a seizure. And the seizure usually lasts somewhere between 30 to 90 seconds. So it's not a particularly long seizure. And of course, the anesthesiologist continues with mask bag ventilation until the person can breathe independently. And then they go to recovery, usually in the PACU as well. And that can last 30 to 60 minutes, depending on the amount of confusion somebody has after treatment. They just had a seizure, so they usually wake up a bit confused. We check their orientation. If they're an inpatient, we typically will discharge back to the inpatient unit when people are awake, alert, following commands, stable vital signs. If they're an outpatient, we'll discharge to home, typically with a responsible escort. And this can be a limiting factor for outpatient ECT. You need to have a responsible escort to take you home. And people are advised not to make important decisions, work, drive, work at heights, et cetera, during the course of ECT, because it can affect their cognition. So how effective is ECT? They certainly claimed it was highly effective, or the best treatment for depression in that video. And there's some data on that, so I'll show you that. It does appear to be the most effective acute treatment in psychiatry. And interestingly enough, it's got excellent efficacy across several diagnoses and syndromes, which makes it unique that way. So major depression, mania, catatonia, very different states, but it seems to work effectively for all three. What's the data on efficacy? There were a number of randomized sham-controlled trials done in the 70s and 80s, all in the UK. And you can see this meta-analysis here. What I'll call to your attention is that the effect size for ECT is pretty large at 0.91 when compared to sham. If you compare ECT to medication, it's similarly large, 0.8 to 1.0. So this is a very effective treatment if you're looking at effect size. And just to compare, if you take a look at medications, the effect size of medications is a sort of small to moderate in the 0.31 range. And then, of course, esketamine, which is a very interesting medication, fairly recently approved. Here we have pretty good effect size at 4 hours, but then it seems to dwindle. And that's an issue, can be an issue with ketamine, and I'll talk a little bit about that later. This was an interesting comparison of ECT to ketamine. It did show ECT to be more effective with a 61% remission rate compared to 45%. Still not too bad with ketamine. And I mentioned earlier, people who are older seem to respond well to ECT. Interestingly enough, they do not respond well to ketamine in general. And if you look at the change in MADRS scores, ECT versus ketamine, the ECT folks started around 34 and dropped to 12, and ketamine 33 dropped to 16.9. So both did fairly well, but ECT seemed to do better. There are a couple of trials going on right now that I think a lot of people are excited about. There's one in the US called ELECT-D. Both are comparing ECT to ketamine infusions. So here people are randomized to either ketamine or ECT, and they receive both, and they receive either, and it's a non-inferiority study where they've defined non-inferiority to ECT as ketamine having a 90% of the same antidepressant effect as ECT. There's another one going on in Canada. The good thing about this one is that they are trying to take in consideration the issue of the effect of ketamine not lasting. And they're doing this by adding a maintenance phase to both ECT and ketamine. So after people are randomized, they are allowed to cross over if they don't respond to their initial treatment. And then after that, they try to maintain the effect. Ketamine getting weekly infusions for a month, then biweekly for 2 months, and finally monthly for 3 months. And then ECT kind of getting standard of care, continuation and maintenance, sort of depends on the person's response and what the clinician thinks. So we'll have to see what those show. If you compare it to TMS, and I know we're thinking about getting TMS here, and I think that's exciting. I know Sheshu's is doing a lot of work for that. TMS does work for treatment-resistant depression. Its effect size is not as impressive as ECT. It's not that bad. It's sort of medium, around 0.55. And another meta-analysis looking at response and remission rates in TRD showed a 29% response rate and a 19% remission rate. But again, this is TRD. It's treatment-resistant depression. It's not people, who haven't failed medication trials. In terms of its efficacy, we can certainly look at acute effects. Another interesting effect is that folks have looked at, and this work was done here by Eric Slade some time back. We all know how important the 30-day readmission rate is. And it turns out that ECT helps people not be readmitted at 30 days. So if you compare folks who got ECT versus who did not with these diagnoses, your chance of being readmitted at 30 days was about half that of other folks. So ECT is very efficacious. I hope I convinced you of that, but it's not a cure and people do relapse. And the first really good study about this was back in 2001, where it was found that if you just had placebo after ECT, no meds, your relapse rate in 6 months was 84%. That's pretty high. And if you were on nortriptyline alone, your relapse was 60%, still pretty high. And then if you combine nortriptyline and lithium, the rate was 39%. A more recent study done with geriatric patients looked at people who remitted. So this study looked at responders and then who relapsed. These were ECT remitters and then who wound up relapsing. So these folks had a more robust response to ECT. And if you combine venlafaxine and lithium, your relapse rate at 6 months was only 20%. If you had maintenance ECT plus venlafaxine and lithium, your relapse rate at 6 months was 13%. So that's pretty good. But again, not a cure. So that's efficacy. How about safety? How safe is ECT? Well, your chance of dying is pretty low. It's less than 0.01%. Serious complication rate also low. So you got about a 1% chance of having a serious complication like a cardiac arrhythmia, apnea, bronchospasm, prolonged seizure, pneumonia, things like that. Common adverse events are headache, nausea, muscle aches and pains, transient cardiovascular stress, and cognitive impairment. I'll focus mostly on the cognitive impairment here. So cardiovascular stress, I think I mentioned, you can get increases in heart rate and blood pressure. Sometimes your heart rate can decrease, or your heart can stop beating very briefly. And we can ameliorate or prevent this by using medications ahead of time. The cognitive impairment comes in a variety of flavors. So you have this initial acute confusional state after the treatment that can last usually 15 to 30 minutes, but in some people it can be prolonged. So if you already have cognitive impairment, the chances are that you can become delirious after ECT, and that can cause problems with management. Sometimes we have to give medication for that. Anterograde amnesia, so the ability to form new memories, can be impaired, especially around the time of the treatment. I always tell people who are inpatient that they will not remember their inpatient stay nearly as well as if they did not have ECT. They're usually not so upset about that, though. This usually resolves in 1 to 3 weeks, but it can be disturbing. Retrograde amnesia, usually again for memories close to the time of ECT, but it can be for more distant memories. And it's also greater for public events than for personal information. So I typically tell people, you're not going to forget who you are, you're not going to forget who your family members are, but you could forget who your congressman is or things like that. And some of this, can be lost permanently, and people have to relearn it. So getting back to the title of the talk, ECT acceptability. So there's been some research looking at how acceptable ECT is, and attitudes vary considerably, but misconceptions and negative attitudes exist among the general public, medical students, and health professionals. Worldwide, many people don't consider ECT a safe or effective treatment. Sources about info greatly affect how you think about ECT, and the studies have shown that most commonly people get their information from a friend, and then films and television, and then a physician or newspapers and magazines. And so, no surprise, individuals whose information comes from a doctor have fewer misbeliefs and less fright about ECT. If you get your information, however, from films and television or a friend, your chances are you're going to have more misbeliefs and be more afraid. And fortunately for people who have ECT, typically their attitudes improve after having it. So patients will often very hesitantly consent to ECT, and then you talk to them later after their response, and they're glad they did typically, and they're no longer afraid of it. That's the typical pattern. ECT has unfortunately been depicted in very alarmist ways through the media over the years, dating back to the 40s and into the 60s. And then for most of us, the 1970s Flew Over the Cuckoo's Nest movie was sort of the one everybody thinks about that is most frightening regarding ECT, where ECT was seen as something that was used to punish people, to punish Randall McMurphy, who was really just sort of a, kind of a ne'er-do-well, but actually had no mental illness. Another one of these cases is somebody who goes into a psychiatric hospital, fools the psychiatrist that he has mental illness, and lo and behold, he's punished by getting ECT. So interesting story, but obviously fiction, and turned a lot of people off to ECT. I think portrayals in general are getting a little better. So for people who watched Homeland, this is Claire Danes getting ECT. We usually don't do this anymore. We usually do the electrodes in different ways, but this is much more reasonable, I think, than prior portrayals. So when it comes down to it, ECT is often unacceptable to many patients, and for two reasons. There is very reasonable concern over adverse cognitive effects. And I think it's important that psychiatrists who give ECT are honest about this. It does cause cognitive problems, and we do advise people not to make important decisions, not to drive within 1 to 2 weeks after getting a course. And then, of course, there's a lot of unreasonable concern or fear fueled by misinformation, including dramatic distortions of ECT. So why do we need to make it more acceptable? Well, basically because despite being highly effective, it's vastly underused. So this is a study done by a group that's done a lot of work on epidemiology of ECT, and published this in 2014. So they looked at really almost 1 million people across the US, and they found that of all those people, nearly 1 million, only 2,471 or 0.25% received ECT, even though we know that about 30% of those folks, or around 300,000, probably had treatment-resistant depression. So you can see here the rates of use, Northeast 0.28%, and it goes way down in the West, 0.19%. And this is due to California, where I think there's particularly a lot of adverse thinking toward ECT. So they concluded that the use of ECT is exceptionally uncommon, limited to patients with extensive multimorbidity and high levels of service use. And of course, the problem with that is that people wind up dying of suicide and other complications of depression who otherwise wouldn't have because they didn't get ECT. So how do we make it more acceptable? Well, there's education of health professionals in the public, so giving talks and doing what we've done here for, I'll say we, sorry, I guess I'm not here still, but I feel like I am. So what we've done here for many years, and I'm not sure who to credit, maybe Mark Ehrenreich, but the students here have always witnessed ECT, and they've gotten some education about it. And research has shown that that's very helpful in improving medical students' attitudes toward ECT. And of course, that's really important because many times it's the physician who will recommend ECT. Be it the primary doc or the psychiatrist, whoever it is. If they know about it and aren't afraid of it, they're more likely to recommend it to their patients. So that's really important. The other thing that I'll talk about in terms of how we make it more acceptable is really the kind of research that we and others are doing to try to minimize the cognitive adverse effects of ECT. So we're trying to do research to figure out how ECT causes its therapeutic effects, how it causes adverse cognitive effects, and how we disentangle the two. So how can we maintain the efficacy and improve the safety? I'm going to talk about just 2 projects we've got going related to ECT. One's called Safety and Feasibility of Individualized Low Amplitude Seizure Therapy, or ILAST. The other's called a Feasibility Study of Transcranial Electric Stimulation Therapy, or TEST, for treatment-resistant depression. And the central question with these is how much of the therapeutic and the adverse cognitive effects of ECT are caused by the electricity that we give, and how much by the seizure we induce. So once Sherletti and Bini introduced electricity to cause the seizure, then the question became, how important is the dose of electricity? How important is the seizure? How do we modulate the two to make it the best treatment we can?
Fill out the form.
So again, the goal with these is to decrease cognitive side effects. So with ILAST, we're trying to do this in a couple of ways. So if you get an off-the-shelf ECT device, the current amplitude you get is around 800 milliamps or 900 milliamps. That is pretty much what we give. And with ILAST, what we're trying to do is, can we induce a seizure and have benefits and make it safer by decreasing that current amplitude to as low as 200 milliamps? The idea here is that when we find somebody's dose with ECT, we will adjust usually the duration of the stimulus or the frequency of the stimulus to try to increase the dose. Here, what we're going to do is keep those more or less constant, and instead go up on the current amplitude to try to find the lowest current amplitude we can use to induce a seizure. So that's the idea. The other thing we're doing with ILAST is try to use a more focal electrode array. So of those electrode arrays I showed you before, this one's right unilateral. You see these 2 large electrodes, and here this is a more focal approach that we're going to take with ILAST. And if you try to understand what's going on in the brain with ECT, and you do these realistic head models that show electric fields in the brain, you can see that with traditional right unilateral, you're really affecting quite a bit of the brain. So where you have anything above sort of this light blue color will induce neurons to fire. And so this is the E field strength that's induced by the current. And you can see that this whole swath of area here is being stimulated at a level where it's causing neurons to fire. If you use this more focal array of electrodes, it's a more focal area of the brain that is stimulated to fire. So that's the idea. Make it more focal and use a lower current amplitude with the hopes that it'll minimize adverse cognitive effects. These are the different arrays that we're using with iLast. Here's the focal, here's the non-focal. And again, if you look at focal versus non-focal, you see that in terms of the realistic head model, you get an electric field that is much smaller in the focal array versus the non-focal array. The iLast device is an off-the-shelf Mecta Spectrum 5000Q, which is a kind of recently obsolete ECT device. It's the company that makes this device has now changed to another one, but we're still using it because the study was kind of devised when this device was being used. But we're adding something to it. We're adding an adapter, and that adapter allows us to obtain these lower current amplitudes because this device will go down to 500 milliamps, but won't go any lower than that. So we have an IDE, an investigational device exemption for this, kind of like an IND, which you'd get for a drug study from the FDA. The overview of the study is that it's an inpatient study. So we have a research inpatient unit, which is great. There really aren't many of those in the country. And we do all our ECT studies on inpatients. We're only enrolling 10 people in the study. There are 3 phases. The first one, we do a baseline assessment where we get a lot of neuroimaging and, of course, scales to assess depression and cognition. In the phase 2, we do the 7 iLast treatment sessions and we randomize them, and it's double blind so that people don't know what they're getting. And in phase 3, we give standard ECT if people have not responded adequately to the experimental treatments. So we usually have this as kind of a rescue phase if the experimental treatment has not improved symptoms. In terms of outcome measures, the primary measures are whether somebody has a seizure and what it looks like on EEG. And then we're looking at adverse cognitive effects, primarily the Hopkins Verbal Learning Task Revised. So it's for those of you who don't know, it's a list of words that you have to recall after about a 20-minute delay. So it's a test of anterograde memory. A lot of secondary outcome measures. So the MADRS depression scale, looking at changes in brain circuit connectivity, changes in quantitative EEG and magnetoencephalogram, trying to understand what's going on in the brain with depression, what's going on in the brain when you stimulate the brain, how it changes when people do respond, how it changes when people don't respond. And then the second study is called transcranial electric stimulation therapy, or TEST, for treatment-resistant depression. The goal here, again, is decrease cognitive side effects. What we're doing here is a little bit different, though. We're decreasing the dose, the overall dose that we give somebody, the dose of electricity, so low that the intention is not to induce a seizure. So we're using a standard high current amplitude stimulus, but here we're reducing the frequency and duration of the stimulus to bring it down below a seizure stimulating level. We're using bifrontal electrode placement. And we're basically questioning the need for a seizure. And you may say, well, why are you questioning that? From the very beginning, you started saying this was all about inducing a seizure and camphor wasn't good enough, so they did injections, and now injections weren't good enough, and now use electricity. But once you threw electricity into it, like I said, it really, the question arose, how important is electricity? How important is the seizure? And it hasn't been completely disentangled. So when I was here, I treated some folks who I couldn't induce a seizure in. That's pretty rare because the machines usually go high enough to do that. But I persisted because I'm kind of stubborn, and it seemed like people actually got better. This was just several patients. And that bothered me. I thought, well, I've been taught you have to induce seizures. Gee, maybe there's some people I don't have to induce seizures in. Maybe I shouldn't be doing that. So I looked at the literature and I thought I was going to find that, yes, there was absolute proof that you had to induce a seizure. And I didn't find that. I guess it depends how you define definitive proof. But like I say, the evidence base for ECT was basically 6 randomized controlled trials in the 70s and 80s. They compared ECT to sham, but sham was anesthesia alone without any electrical brain stimulation. So that didn't allow us to tease out the electrical brain stimulation part, because there really hasn't been any study that's compared regular ECT to anesthesia plus some form of electric brain stimulation that's like ECT, but not enough to induce a seizure. So that's what we're trying to do in this study. And as some of you know, we did a open label study here, that was funded by the Brain and Behavior Research Foundation. Back then we called it NET, or non-convulsive electrotherapy. And we published those results in Brain Stimulation. Again, open label trials, so you don't know how much of the improvement in patients is due to electricity and how much of it is due to the great sense of humor of your anesthesiologist, Rob Narani. But fortunately, we didn't hurt anybody. There were no serious adverse events. We had, of course, adverse events, and a lot of it were stuff you'd see with ECT, like headache, fatigue, jaw pain, variety of things, but nothing super serious. We did have response by most patients, but certainly not all. But the response rate was enough to encourage me to go on and try to propose doing another study. So to dig down a little bit into the test or transcranial electric stimulation, like ECT, test again uses a high amplitude current, but we lower the overall charge delivered by decreasing the pulse frequency and the pulse train duration, because the overall stimulus charge is a combination of the pulse amplitude, the pulse width, the frequency, and the train duration. So to make it a little schematic here, with test, the experimental treatment, we deliver at a low frequency of 10 hertz and a duration that's pretty brief. So the stimulation only lasts between around 1 and 2 seconds. This is kind of a schematic of that. And if you compare that to ECT, where you are giving a more high frequency stimulus over a much longer train duration, up to 8 seconds, that's why ECT has a much stronger stimulus and is able typically to induce seizures. So that's how we reduce the overall energy of test so it doesn't induce a seizure. Now you might say, how does that compare to TMS? TMS is also brain stimulation that does not induce a seizure. Test is very different from TMS. And I'll show you how it's different. Basically, with TMS, we are using a magnet to induce a pretty weak electrical current just below the surface of the brain in the cortex. And you can see here, the realistic head model shows a very focal area where we get brain stimulation to cause neuron firing. Whereas if you use bifrontal ECT electrode placement and use a high amplitude current, like we do with test, you get this pretty massive frontal stimulation. Now, again, that's so brief that it doesn't induce a seizure, but you can see the big difference here between TMS, very focal, and test, which is high energy and not very focal. The test device, well, nothing fancy. This is an off-the-shelf ECT device where we just dial it down to the lowest energy possible. Nothing very creative there. Despite that, we had to get investigational device exemption from the FDA because we're basically using it off-label. We're using it as a brain stimulator, but not with the intention of inducing seizures. Overview of the study, we're hoping to have 30 completers. Phase 1, we have a baseline assessment. Phase 2 is a randomized controlled double-blind comparison of test to sham treatment. So here we're comparing test to anesthesia alone for 6 treatments over 2 weeks. So you're randomized to getting just anesthesia or test. And then we repeat the baseline assessment. And then after those 6 treatments, if you seem to respond, well, if you got sham, you're automatically switched to the experimental treatment. So everybody will get test. If you got test initially and you did not respond and you want to have ECT, you can get ECT. We won't tell you you're getting it initially, but you'll get it. If you did respond to test, you'll continue getting it unless you reach a certain level of futility where you're no longer getting better, in which case we would switch you to ECT. So that's how that's going to work. And the most important part in terms of deciding if it's, if it's effective or causes side effects is really this randomized double-blind control comparison to sham. And then there's a phase 4 outpatient segment where we'll follow people for 6 months to see how they do. So the primary endpoints, again, Hopkins verbal learning. We want to know, does it impair memory more than, say, just getting anesthesia? Also, can we consistently stimulate without inducing seizures? And we're also looking at change in depression scale score as a secondary measure. So ultimately, the question we're asking with all this research is, can we improve ECT safety and acceptability by reducing adverse cognitive effects while retaining its therapeutic efficacy? Or in other words, can we avoid throwing the baby out with the bathwater, which is a distinct possibility. So the thing about ECT is that it is not very focal. It's a pretty strong stimulus, and some people will say that, well, that's why it's so reliably effective for people. And that could be the case. But the thing is, we do know it causes side effects, which reduces acceptability. So I think it's worth trying to tweak it. I want to thank all the members of our research group and also our friends in anesthesiology at the NIH. We could not do this without them. And I open to any questions or thoughts you have. Thanks for your attention. Appreciate it.
Thank you very much, Dr. Reginald. So what we can do is, for our in-person folks, I'll pass the microphone around, and anyone online, just raise your hand in the chat room. Maybe I go ahead and get started. So I have so in the eyelash, you're looking at many different electrode placements.
Yep. Yeah.
In the test, you've chosen bifrontal.
Right. Yeah.
What does that say about why do you think ECT works? Like, what are you saying about the mechanism? Because in one, you're saying I'm looking at this part of the brain, and the other, I'm saying, well, I can stimulate a whole bunch of parts.
Right. Well, yeah. So eyelash, the idea with eyelash is eyelash accepts the idea that the seizures, the reason ECT works. And so it's saying, okay, it works through a seizure, but let's try to make, let's induce a seizure, but let's make it a more benign inducement. And let's look at the various different electrode placements we use to see if, in these various placements, eyelash has, a better profile in terms of safety. So that's kind of the rationale for doing it that way. The rationale for bifrontal placement with test is really kind of twofold. One, that's what I used to stimulate the folks I couldn't get a seizure in originally clinically, and they seem to get better. So I didn't want to change that. The other rationale is, and we didn't get into this kind of detail, but you know this, how much energy used with ECT really often depends on the electrode placement. So the right unilateral placement I showed, research has shown that if you give ECT with that placement, then you have to give a much higher dose of electricity. So there were 6 trials done for the evidence base of ECT. The only one that didn't show ECT was better than sham was a study done in the UK where they used right unilateral placement of electrodes, and they stimulated at only 10 joules. And later people found out through research that you really have to stimulate way above seizure threshold. So about 5 to 6 times seizure threshold to get a reliable therapeutic response with right unilateral. So of course I wasn't going to be stimulating with right unilateral. I wouldn't do that because the research has shown that you really have to use high energy to get it to be therapeutic, whether it's due to the high energy or it's due to the seizure. That wouldn't work. And then of course bitemporal, I know that causes the most cognitive side effects. So really for a lot of reasons, I chose bifrontal. Yeah. Yep. Sheshu, yeah. Hi.
I don't even know when you left from here, so um, basically I have a couple of questions.
Yeah.
Just attended EMS course at Duke.
Oh, great. Yeah.
One of the things that is going on is the trend is not to focus on structure of the brain, functional neural tracking. So you don't have to focus on, if I can focus on particular area, I will probably focus on Brodmann's area 25. But we are focusing on dorsolateral prefrontal cortex, EMS, because it indirectly stimulates the area we want to. But there is a big argument because with the BrainSway, the new instrument, they're saying the results are better because it is not focal, it is more towards diffuse. So we are going back to the same argument with ECT we had. Is it better, like Max Fink used it to say, it is better to give bilateral with high energy rather than playing all around with the right unilateral. So you have any thoughts about it?
Yeah, that's a good point. So as Sheshu pointed out, this idea of specific versus non-specific is even there in the TMS literature. So there is one TMS device which gives so-called deep TMS, and this is like more of a helmet you put on somebody as opposed to that figure 8 coil, and you can reach deeper into the brain that way. And I guess I can't say I'm an expert on the research on that, but maybe some people do argue that it's more reliably effective because of that. Yeah. Right, diffuse, okay. Okay, right. So more diffuse, thanks. So yeah, I think whether it's TMS or whether it's ECT, I mean, it seems like whatever you're doing to stimulate the brain, insofar as you know where to stimulate, where to target, to cause a therapeutic effect, and you can do that, you can individualize it and do it precisely, you're more likely to improve mood or improve whatever symptoms you're trying to improve and cause less side effects. And the problem is that we don't really know where to stimulate. I mean, in any given individual, right? So as our field progresses and we try to understand this better and better, the hope is that we will move toward individualizing these kind of stimulation treatments better, be it ECT or TMS. In the meantime, yeah, I mean, it maybe this sort of more diffuse stimulation is more reliably effective because we don't really know where to stimulate. The hope is we will eventually, and the problem is that if we just keep doing it diffusely and we keep causing cognitive side effects, we're turning off a whole segment of people who are very risk averse. I mean, some people are like, give it to me, doc, I'm so depressed, I don't care. And then there are other people who are, they're just completely freaked out by the idea of having a seizure or having any cognitive impairment. Even if you're trying to convince them that, look, you're about to kill yourself, you tried to kill yourself, et cetera, they're still freaked out. So yeah, I hope that we can figure out what's going on in the brain more so we can target things better to each individual. So we're not giving, yeah, go ahead. Right. Yeah, maybe that's the new wave. And we have these things where we can understand brain function better, and then how do we integrate them into clinical care? They're very expensive, and there's a whole bunch of training you need to learn how to do this. And so we're in the early days of this. I guess that's the hope.
So we got a couple of questions from virtual land, and then we'll get Dr. Gould and Dr. Schwartz. So first off, are heart conditions often / usually exclusionary for ECT trials? And does ECT primarily get used in elderly patients because of the cognitive effects?
Oh, okay, those are good questions. So it really depends on the cardiac condition and whether it is compensated or not. So we've certainly done a lot of ECT on people with heart conditions. People have had heart attacks, et cetera, people who have had heart failure. And it really depends on to what extent they're, acutely ill. So we try to get people as stable as possible. So if they have heart failure, we want to make sure they're as compensated as possible. And if they've had heart attacks and they have history of ischemia, we want to make sure they're, solidly on their meds to decrease risks. And then it just comes down to a risk-benefit ratio, discussing with the patient and talking about the risk with them. But we definitely, it's not a contraindication to do ECT on somebody with a heart history. The usual advice is if somebody's had a myocardial infarction, you want to wait at least a month and make sure they're stable, but you can go ahead and do ECT. So that's that. And then with the older folks, I think there are a couple reasons why I think it tends to be more, we do ECT more with the older folks. It's not because they get more cognitively impaired, but it's because, for one, we know they respond better, but the other thing is that they tend to, two other things, they tend to not tolerate the meds as well. So they're on more meds, they have more interactions, they're more prone to not tolerating the side effects, to having a variety of side effects that they can't tolerate. And so that leads us then to move toward other treatments, non-medication treatments. The other reason is as people get older and they get severely depressed, they have this bad habit of stopping eating and drinking and coming in, very debilitated and, many times winding up on a medicine unit before coming to the psychiatric unit. And so it's really important to get them better pretty quickly, and ECT works quickly. So that's, I think, another reason why older folks tend to get ECT.
We have one more virtual question, then we'll go to our in-person. Recent preclinical and clinical studies suggest that isoflurane anesthesia on its own has antidepressant properties. Would that affect how ECT studies are designed or how anesthesia may be incorporated into the ECT treatment?
Oh, that's interesting. Yeah. So, there is an interesting kind of small literature on isoflurane, and I'm not sure if this was Paul who asked that question, but it's an interesting topic, and we've delved into it a little bit here at one point. So isoflurane is an inhaled anesthetic, and there's some data that suggests that it could have, if you bring somebody down basically into a coma with isoflurane and you keep them there for around 15 minutes, and then you bring them out, and you do this serially, there's some data that this has an antidepressant effect and possibly causes less cognitive side effects than ECT. Now, I don't think there have been randomized controlled trials with this yet. At one point, we thought about getting involved in this. This is a group at Utah that did this. The problem I see with it is that bringing somebody down into coma and keeping them there is a bit risky itself. It may not cause as many cognitive side effects, but there are certain other risks involved. So I've been hesitant to really go whole hog on that because I worry that it's maybe not the most practical approach to treating depression. But it could well be that this serial use of isoflurane-induced coma has an antidepressant effect. I guess we'll have to see if there are randomized controlled trials. Again, I was a little bit scared off because I wasn't convinced that it was going to be super practical. So, but a really good question, and I should probably go back to literature and see what's the latest on that.
Bill, first of all, thanks for the presentation.
You're welcome,
Todd.
Todd.
That was excellent. I really learned a lot. I have a couple of questions.
Yeah.
So the first is thinking about the relationship between cognitive changes and efficacy of ECT.
Yeah.
I'm curious what the literature indicates. I'm sure there's been studies that have asked whether the cognitive changes predict efficacy or if there's an inverse relationship.
Right.
And the second question is more general. I'm just trying to get a sense of the central hypothesis that's guiding your research, like mechanistically. Could you briefly tell me how you and your research group thinks that ECT is working?
Okay. Sure. So in terms of the relationship of cognitive side effects and therapeutic benefits, there seems to be no relationship. Okay. So insofar as somebody gets cognitive side effects, it doesn't seem to be related to their extent of therapeutic benefit. So that's pretty clear. In terms of how ECT works, So I think in general, the field thinks that brain stimulation may work by causing neuroplastic effects and, therefore kind of improving brain connections, which help medications work better, help modulate brain circuits that are perhaps not acting adequately in depression. But that's as much as I can tell you. I mean, we don't know. I mean, I think the sort of neuroplastic hypothesis, about ketamine, about brain stimulation, and also about just the regular, antidepressants that Ron Dumont used to talk about and did a lot of animal work. And I think that's still the kind of prevailing hypothesis. And it could be true. It's just that, that's an idea that now we have to sort of bring, apply and figure out in each individual, where do we need to cause that neuroplasticity to get you better? And that's obviously a lot of applied work, and we're, a lot of work to be done there. Does that help at all? Or? Yeah. Yeah.
Sorry, is it okay now? So welcome back, and really
good to see you, Robbie.
Really enjoyed this talk.
Yeah, thanks.
Just to double up, and now in the discussion we're getting into mechanisms. You mentioned mechanism a couple of times in your talk, but now we're getting it. So from a basic science point of view, first question is, how much can animal work really help you with this? Because we know we can give drugs to animals, that's easy. And what about the electrical response that you can check in animals?
Yeah, I'm not very sanguine on the animal work, only because I'm not confident that we can really, mimic depression in the animals. I think the animal work can be helpful with safety. So the lab I'm in, the PI has done work with macaques, looking at the brain after giving ECT to say, see, it doesn't cause brain damage. Okay, I think that's helpful. I think just like in toxicity studies in animals, what's the LD50 of this drug? I think there's definitely a place for that. But in terms of understanding therapeutic effects or adverse maybe you could do some work with adverse cognitive effects. Maybe it'd be tough. You'd have to get the animals to do some task and et cetera. But I just don't have a lot of confidence in animal models of psychiatric disorders. I mean,
Oh, wow.
sorry, guys.
Todd and I will talk.
I don't. I mean, I wish I did, but
Is Jill here?
and it's not like I haven't done animal work. I have,
Please listen to this.
not like you guys, but I mean, I just,
No, it's good.
I don't know what else to say other than that.
We have a quick question,
Yeah.
particular question about, I was trying to listen here. Did you do any studies? You compared ketamine with ECT and others.
Well, I didn't.
But yeah, no, I know
yeah,
people did.
Yeah.
Maybe I missed it. Were there any studies where they combined the two?
Yeah, there have been. So because ketamine's an anesthetic, and also I don't think I fully answered that other person's question about isoflurane, because I think part of that was maybe combining isoflurane with ECT. So people have done studies combining ketamine and ECT. It doesn't seem to have any great benefit that would counterbalance the negative aspects of using ketamine as an anesthetic. So ketamine isn't the ideal anesthetic because it tends to cause blood pressure changes, for instance. So it's not the go-to safe anesthetic for ECT. If it seemed to cause added therapeutic benefit that was significant, then I think there'd be an argument for combining it. But so far, the studies haven't shown that. And isoflurane, using that with ECT, that's an interesting question. It would really kind of depend on how easy it was to induce a seizure on isoflurane. It may be pretty difficult. So, so that would be kind of the rub there. Whereas with ketamine, it's not difficult to induce a seizure. In fact, it's probably easier with ketamine than with the barbiturate that we use. So it makes sense to try that with isoflurane. I don't know. I'm not an anesthesiologist, but it would suggest to me that maybe it'd be tough to do a seizure. to induce a seizure on isoflurane. Could be wrong, but yeah. Hey, Dave. Good to see you. Yeah, I can hear you. Okay. Yeah.
I know one's incredibly deep, but one's incredibly peripheral. What are the lessons learned? Is there any way to merge that literature?
Yeah, good question. I mean, yeah, I mean, DBS is really trying to figure out, be more precise about targeting, obviously. It's like, okay, and there, as many of you know, there was a big study done some years back across the country, the Broaden trial, where people were hopeful about pinpointing this area of the subgenual cingulate. Unfortunately, it was stopped due to futility. It just shows how tough it is to figure out, to individualize targeting. So there probably were people who got better in the Broaden trial where they hit the mark, but not enough did. And so how do we individualize it? Sheshu was saying, well, functional imaging, and that's probably a good approach to take, and that seems to where the field's going. So to use TMS to change the function of the subgenual cingulate or some area, some other circuit, you could change it, or like provoke it first, show to the depression, and give the treatment. Show in that N=1 study that the person's mood changes, and we found it. And that's what they do with DBS. It's like they're stimulating and they're looking for that area where the mood changes, but it's so invasive, that it's hard to do these big studies. It's obviously getting holes drilled in your head and having electrodes in. You have to have pretty treatment-resistant depression to be pretty desperate, because that's pretty serious. So it's hard to do that kind of research. Ethically, it's challenging, and safety-wise, it's challenging. Our group hasn't done that. We do talk about it with other groups. There's a neurosurgeon at NIH who's interested in doing it. I think I would jump into it, but I would do it very cautiously.
And what about just in the DBS studies with Parkinson's? Was there any where actually depression associated with Parkinson's was depending on where the DBS was done?
Yeah, that's a good question. I can't say that I've really looked at that literature well, Dave. The great thing about the motor system is it's mapped out. We know where to put the electrodes. It's wonderful. And I think the folks who were trying to bring this over from Parkinson's to depression were hopeful that they had the major person who did it, Helen Mayberg, was a neurologist. Actually, I did work with her when I was a resident at Hopkins, and that sort of neurology point of view of, okay, there is a region that's gone bad, and we're going to put something there and we're going to fix it. It's worked for the motor system, but now it's for the emotions, it's tough. I mean, it's a lot tougher to figure out where to target.
I'll just
My final question, just as a quick one.
Yeah.
Do you ever, this is just more of a basic clinical, I mean, do you ever have issues with more ethically with the person's capacity to consent?
Oh, yeah. That's a really big area in ECT. And it's very challenging because many times you have people who are super sick. The sickest ones are the hardest ones to consent, obviously, because they can be the most impaired. And, if you don't think people are competent, then you really have to you have to go to a court. You literally have to go to the Clarence Mitchell courthouse. And that takes time to set that up. And I've done it. But, you've got people's lives on the line, like some of them are on feeding tubes, or they've got IV lines in, and they're on the verge of going to the ICU. So, you get family involved, and you make sure family's behind it. You do your best to make sure somebody's competent. Have I encouraged people too much at times? Maybe, but if I've done that, it's always been with family nearby in favor of it. It's never gone wrong. I've never had a situation where afterwards people go, "Why did you do that to my dad?" It's never happened, luckily. But yeah, it's tough. I mean, it's highly regulated. In some places you don't have to go to court. You just need like two. In England, when I was training there, we just need 2 independent psychiatrists who would say, yes, this person needs ECT. In California, it's really hard. That's one reason why ECT is used less there. So consent's really important, obviously, and it can be tricky with ECT. Yeah.
So we got a couple of online questions and I'll turn over to Dr. McClam who can wrap us up. So the online questions I'll summarize because they're mechanistic. One is, do you think that the mechanism of TMS and low dose ECT may be the same? And if so, what is that? And number two is, on a neurotransmitter level, do you think glutamate may be involved, such as it is with ketamine?
Oh, well, good questions. I think it's hard to know about the mechanism of what we're calling test and TMS, whether it's similar. You know, we're targeting the frontal lobe in both, much more focally with TMS. You know, the stimulation is super brief with test, it's super long with TMS. So I would doubt the mechanism similar just because of the incredible difference in stimulations. But I don't know. Wait a minute, glutamate. It's hard to know. I mean, glutamate's, you know what, it's the most common neurotransmitter, right? It's the, Robbie, you can tell me, right? It's the, yeah. So, oh, I don't know. GABA's close, I guess. But, you know, they balance each other. But, you know, could it involve glutamate? Well, at some level, it must involve glutamate, right? Because it's all over the place. How important is glutamate? I don't know. I mean, I think glutamate's obviously involved in neuroplasticity, so it probably has a role. But exactly what that role is, you know, and how you use that therapeutically, I don't know. I mean, that's over my head. That's a great question. That's probably over my head. So my stupid answer is, yeah, it's involved because it's all over the place, but I don't know how. So how's that? Sorry, it's not very good.
Mainly the electrical. Joke, everybody's saying the brain is an electrical organ, and it is what we are doing is electrical stimulation. The secondary effect is neurotransmitters.
Second, yeah, right. Yeah, so we're causing the firing of the neurons, and then of course neurotransmitters get released, and the neurons talk to each other, and the circuits modulate, and all that stuff. And glutamate's undoubtedly involved, but it's over my head to understand exactly how that works.
Okay, this is a very generalized question.
Yeah.
Is there any research or work being done looking at other indications for ECT? I do know at times ECT is given if someone is in status epilepticus. There have been times where I have also seen ECT treatment used if someone has obsessive compulsive disorder and they've got a lot of self-injurious behaviors and repetitive compulsion. So is there any work that you know of that's done studying and looking at that and seeing how that mechanism of action how ECT's mechanism of action may help with those cases?
Yeah, that's great. Yeah, there are a lot of very interesting areas where ECT is tried, and you know, we've certainly done some work with status epilepticus here, and Shesha has been a major force in that, and Chris. Yeah, I mean, it's amazing that it can help this wide variety of things. And again, that kind of brings you back to the idea, maybe it's so effective because it is so non-specific. You know, and it can do wonderful things for autistic kids with, you know, problematic behaviors where they're injuring themselves. In fact, you know, there's a group at NIH, we have an inpatient child ward that's devoted to autoimmune induced psychosis. And a lot of those kids get catatonia, and they want to start doing ECT on those kids eventually, because it does work. It does bring kids out of that. How it works for catatonia versus how it works for depression, I don't know. It's so hard to do work on people who are catatonic because, you know, they can't consent typically. I mean, you know, or it's really hard. I mean, if you can get them consent to clinical ECT, then, you know, somehow, then that's wonderful. Like, how do you get them to consent? Certainly at NIH, it's so highly regulated. I can't imagine. I don't, but you could get substituted consent, and there is such a thing. It's just it is so tough, you know? Yeah.
So we do that here. We do a lot of emergency guardianships, and it's virtual now, so you don't have to go down to the courthouse. But we have gotten a lot of emergency guardianship to treat patients with catatonia here.
Yeah, absolutely. Yeah, that's the way to go. And yeah, so everything I've seen on catatonia has been pretty much a case series. I've never seen anything randomized controlled. And in terms of the, autistic kids with problem behaviors and OCD, I mean, I don't think I've seen anything randomized controlled there either. It's pretty much case series. And that stuff's encouraging. I think it's just so hard to, as people say, work in that space that, it's easier to do depression and tweak that, but, maybe some of us will get the courage to do it sometime. Yeah.
Anybody else? Let me look out in the virtual world before we wrap up. No, I think that's all. Thank you very much, Dr. Regano. We really appreciate it. Wonderful discussion.
Fun. Thanks for all the
Happy
great
to have you
questions.
back.